Yes, this is EM Case's Best Case Ever mini podcast series, and I'm your host, Dr. Anton Hellman. It's my great pleasure to have back on EM Cases Dr. Melanie Baimel from Sunnybrook Hospital in Toronto, who was one of our guest experts on one of my favorite podcasts that we've done on EM Cases, the emergency management of hyponatremia. Dr. Baimel, welcome back to EM Cases for your best case ever.
Great. Thanks, Anton. So I have this great case of a 50-year-old male who presented in cardiac arrest, no past medical history. He arrested in the car with his wife and was very sudden in onset. CPR was started within 5 minutes of him losing consciousness, and he was brought into our emergency room in PEA. We did CPR and all the usual ACLS things and were able to obtain a return of spontaneous circulation. However, his heart rate was profoundly low. He was in the 30s. His QRS complexes were wide and there were no P waves. His blood pressure was also extremely low, despite being on 3 pressors. And so we decided to try and pace him. And unfortunately, the pacer wasn't capturing. And we kind of all scratched our heads. And fortunately, cardiology arrived because, we were concerned that the patient obviously had suffered a primary cardiac event, like a big RCA infarct. And they suggested that we try stabilizing his membranes with calcium and shifting him. And sure enough, the pacer started to capture the QRS complexes. His heart rate came up and his blood pressure improved. And he was taken up to the cath lab and stented.
All right. So all along, he may have well had a huge MI, which can certainly cause bradycardia, but he was also hyper-K.
Yeah, he sort of had a double whammy situation where I believe the RCA infarct was contributing to the bradycardia, which was our initial thought. And because he had had a prolonged downtime, he had become acidotic and hyperkalemic, and that was interfering with the pacemaker's ability to capture the ventricular beats.
All right. So what did you learn from that case?
So the lesson that I learned from this case was consider hyper-K if the usual interventions aren't working. So to really think of widening my differential and first and foremost, thinking about hyperkalemia, because really it is the great imitator and it can fool you every time. So in this case, this patient had 2 things going on. He did have an RCA infarct that was contributing to his bradycardia, but in addition to that, he was also hyperkalemic and acidotic, and that was interfering with his perfusion and rhythm as well. So just remember, if what you're doing isn't working, to sort of pause, take a step back, and use a cognitive forcing strategy to explore a wider differential as to what might be going on with your patient.
All right, great case. So for more on how to finesse your management of hyper-K, join us for our upcoming main episode with Dr. Baimel and Dr. Ed Etchels.